on the screen, there is a question that we would like everyone to answer today. It'll be one of our learning questions. So we'll keep that up while people are joining. That'll be our joining activity, if you will. And so we would like to have that question answered in the chat, but we understand that some people who are outside of our organization may not have policies that will allow them to participate in the chat. So if you can't participate in the chat, please put your answer in the form that's provided. A few more minutes to a few more people to join. And that question, by the way, is not a binding question. If you not exactly sure what your boss would say, that's okay. You could just give us a preliminary answer of what you think might be the issues that your organization is facing. We're not going to hold anyone to that. I guess that's my way of saying this is not, your answers are not binding. So. I'm going to wait for about a minute and a half, and then we're going to get started with preliminary stuff, and then we'll circle back around to this. All right, let's go ahead and we'll get formally started to the title slide. So this is, of course, our quarterly meeting of the Hospital Data Forum, which is part of NADO's Hospital Data Initiative. And I think most of you know me by now, but if you don't, my name is Norm Thurston. I am the Executive Director here at NADO. And I still hear the joining bells going off. So we'll come back to our joining question here in just a minute. But just by way of introduction, if you're not familiar with NADO, NADO is a national nonprofit membership and educational association that is dedicated to improving healthcare data collection and use. This is our 40th anniversary, if you will. Coming up, we're in our 40th anniversary year. And so our origin story takes us all the way back to the very beginning of the collection of hospital discharge data and providing standards and opportunities for doing that. So, of course, as you are well aware, NADO is committed to supporting our members who participate in the collection of discharge data from hospitals and other facilities, and that would include data on hospitalizations, emergency department data, ambulatory surgical data, and other similar sorts of things that some of our members are collecting. And we want to add support for the growing needs of hospital discharge data collection and use. It's a program that for many of you has been around for a while, but in changing world that we live in, the world of data today still requires support. So in order to do that, we've created the Hospital Data Initiative, and that is intended to add a value to our current members who are operating those data programs. And that initiative has three main areas of focus. One is the Hospital Data Forum, which we're having today, the creation of educational materials, which I can briefly mention that we have already published our Hospital Data 101. If you have not seen Hospital Data 101, it is a series of 4 short videos that are intended to help people who are savvy with data but have no idea what hospital data is to get them up to speed. And so we would encourage you to take a look at that and use that to educate or inform your workers or your friends. And then finally, to increase collaboration and coordination with the HCUP program within ARC. So the purpose of the Hospital Data Forum, which we're doing today, is to tackle ideas and networking. We have done that 3 times in person: Boston, New Orleans, and Austin. And of course, the general takeaway is that once a year is just not enough. It's hard for everyone to get there, and then we just find that it's not enough. So our quarterly schedule is now set that we meet February, May, August, and November, with May being the in-person event. The 2026 meeting will be the second week of May in Miami, Florida. Our general format is a short presentation on a topic of common interest. And then we want to have as much interaction as possible for you to ask questions of each other, share best practices and learning. By way of review, here is what happened at our last meeting in the in-person meeting in Austin. There was a lot of discussion, and you can imagine in May this was even more alarming, the discussion about funding cuts and reliance on federal funds that threaten program continuity, and then strategic solutions to that question: diversifying revenue, enhancing value, and modernizing technology. So standardizing formats, leveraging AI for admin, and updating infrastructure. We spent a lot of time talking about that as well. So it wasn't all about the money. There was some discussion about technology. So we're going to go back to the beginning for those of you that have joined. And this is our question that we would like to learn more about from you. What challenges does your hospital discharge data system face today? And you can see that many people have responded already in the chat. If you don't have access to the chat, you can respond by going to that link right there. And so we're going to collect that information, and that will be feeding into our future discussion items going forward. We want to always be aware of what issues you're facing so that we can plan our hospital data forum activities accordingly. So we'll leave that on the screen for a bit longer. I guess what I'll probably do is just continue on, and then we'll put this back on the screen as people get a chance. And Charles is going to continue to monitor that. Also, just in case anybody is wondering, we are recording this meeting, and it is transcribed. The transcription will help us with note taking. We will not publish the transcript, but so that if you are seeing the transcript, that's what that's for. The comments will not be for attribution in the transcript. All right. So let's go ahead then and take a look at those challenges that people are facing and have a brief discussion about that. Let me get back to that. Get on the screen and reading in the chat. All right, so let me just take a look at a few of these. I'm hoping that you're all able to see this as well. So compliance issues, getting data submitters to provide data. We definitely can have a conversation about that one. And both that's complying with, I assume, complying with the data format, but also just complying with getting the data in. Irvin mentions data capacity for electronic submissions of rural clinics. So some of the smaller institutions may not have the capabilities to submit according to the, and Richard mentions that as well. Small facilities like ambulatory surgical centers especially don't have the technical expertise to provide data in the format that require. Don mentions the dates in the hospital discharge, they do not always line up with the dates in the APCD medical claim. That's an interesting observation. And then we're definitely concerned about cuts and reorganization at ARC and the effect this may have on HCUB. So we can come back and talk about that one. Let's just have a brief open conversation then about compliance, and I think we'll just maybe focus for today's purposes on those who are less savvy. So there are many issues and reasons why people may not submit or may not follow the protocols that they're supposed to protocol. But let's just assume that they are smaller institutions who lack technical resources or the knowledge to do that. If you'd like to comment on that, please raise your hand, and we'd love to have you join with us and share your thoughts. See, Natalie, go ahead.
Hi, everyone. This is Natalie Helbig from New York State. We continually have same problems with smaller ambulatory surgeries, facilities not being able to submit the data appropriately. One of the things that one of our hospital associations in New York State did was create um, a program where they submit on the hospital's behalf or on the ambulatory surgery program's behalf, kind of like an intermediary between one of the vendors, like Epic and others that are, some have the money to, put in the contract and some don't. So that was one thing that's helped with improving submission for some of those. Um, but I don't know if every state has active hospital associations or not.
Interesting thing. So basically the application more broadly would be is that some association or some intermediary would provide a service or a tool so that they just didn't have to worry about it. I think that's the way
Yeah,
I would just, yeah.
yeah, exactly. Yeah.
Yeah, and that would depend on what resources. I think we had a question here from Alaska, and maybe or maybe not. Alaska has those resources. I think Alaska is a different size state than New York, so maybe we can ask. Maybe we can have them comment about that one. Richard, you
Yeah,
had your hand up a couple of times. You want to join?
yeah, thanks. So Alaska, our discharge data program used to actually be administered by our hospital association until the state basically took it over. But we do have, like, especially for some of our tribal health centers, like our Alaska Native Tribal Health Consortium sometimes acts as that intermediary for those clinics and hospitals, and reports data on their behalf. It generally that works pretty well, and except in cases where like something might go wrong in that chain. And we've had issues recently where like having that extra layer between the facility itself and our program has actually kind of created like more problems because when we have to troubleshoot like data at a specific facility, like counts might be, for example, for us, counts were like way lower than we were expecting. So we actually had to like reach out to the facility. The facility had to reach out to the tribal health center. The tribal health center had to reach out back out to the facility. So there was like a lot of back and forth, and it just kind of introduced this extra layer of communication where things get mistranslated or lost, or we're not, some folks aren't on certain chains, and so it's kind of like a double-edged sword in some cases having that intermediary, because like the benefit is you definitely like the bigger, they might have more resources than the individual facilities, but then you kind of lose some of that direct interface with the facility itself, which can kind of make it difficult to troubleshoot problems. But that's definitely like, I think a good what's the word I'm looking for? Um, Opportunity for smaller facilities to take advantage of if like a hospital association or like a tribal consortium can kind of take some of that burden off of those smaller facilities. Just kind of have to balance it with like the uh, basically still having like direct contacts at those facilities who can assist with data quality issues or troubleshooting things.
Thank you, Richard. Uh, Anyone else want to kind of comment on ideas that you have had or that have worked for you to help those less sophisticated or smaller facilities to get their data in timely, in the right format, et cetera, complete all of those things that we are always shooting after? Anyone else? Okay. Yes, Natalie, go ahead.
Yeah, you guys probably already do some of this, but we ebb and flow with how often we do it. So, in New York, we have a vendor, so we do have some of the vendor staff that can help with the technical aspects of submission. However, we still found even with that, one of the things that we did was increase the number of what we call data submitter forums, where we just hold a hour-long meeting every month, because we found that there was a lot of turnover at some of the smaller facilities. And it was like every other, 6 months, somebody was getting onboarded or had to pick up what someone else was doing. So we recorded those so that people could go back to them, do some, asynchronous learning on their own time, um, and just gave them an opportunity to, call and hear from peers. So that kind of worked a little bit. I wouldn't say it solved everything, but.
Yeah, that totally makes sense. All right, let's take just a couple of minutes on the other question that Don submitted, which is what to do when data that comes into the hospital discharge program doesn't match up with data in another source. For example, the all-payer claims database. In particular, Don mentioned dates, so that the dates that are getting through the hospital discharge submission system do not match the dates for the same encounter in the all-payer claims database. Does anybody, Don, do you want to maybe comment on that if you've actually proposed or found a solution to address that?
Oh, I don't have a solution. It's just kind of makes it difficult sometimes to try to uh, put a fingerprint that's to kind of tailor one-to-one on the uniqueness, because we have de-identified hospital claims that we use with our APCD, which is also de-identified. And so we try to match things up as close as possible. And sometimes we find that, it's not like it's all the dates are wrong. It's just when you're trying to chase outliers, and that's what you're kind of looking at as the edge cases, it tends to pop up as something that would, if the dates did match, would be a lot easier. But there's ways to explain it too, because sometimes the hospital discharge isn't coming from the EHR and it's a separate thing. It just depends on how the data is collected and submitted as to whether the dates get. Sometimes it's on the claim, like on the billing side. So maybe a medical billing will change a date or something because of a charter update or something. So sometimes there's updates to the claim after the fact that may adjust things. So it's really hard to know which source is right. I tend to think that the APC medical claim is going to be better because it's got a better chance of being updated in version, so to speak, so that we can have opportunities for revisions. But it's just something to know that when we come across it, we don't have that expectation that things are going to line up 100%.
So, and the upshot of that is, as you mentioned, it's when they are de-identified. Because if you knew who the patient was in both databases, it's pretty simple to reconcile that. But it's when you don't know who the hospital patient is and you don't know who the claim is paid for, then if the dates don't match and the services may or may not match, it makes it challenging to reconcile what actually happened and what was actually paid. I think that is a valid concern. Does anybody else have any suggestion? I'll go ahead, Don.
I'll say it's something that we kind of do to kind of a double check on medical claims to make sure that our facility information is accurate as well, because sometimes we get facility information that doesn't quite line up with the hospital discharge as part of the claim.
Yeah.
So
that's actually another sort of separate point, but a good one as well. We have had a lot of interest lately in external validation. So there are tools and techniques that you can use to internally validate your data. So you can track things like frequencies and trends, and et cetera, et cetera. But external validation is also very interesting to make sure that you're getting all of the data that you're supposed to get and only the data you're supposed to get, but in the correct, that things are coded correctly, that it's input correctly. And so APCDs do provide an opportunity for external validation of the hospital discharge data when they're available. And there may be other sources. Yeah.
Yeah, I don't want to make this seem like it's a big deal. It's just it's enough. It happens enough to where it's something that we have to account for when we look at it in the population as a whole.
Yeah. Yep. Absolutely. That makes sense to me. All right. Anybody else have any thoughts? John, go ahead.
Yeah, having trouble with my microphone. Can everybody hear me?
Yes.
Yeah, so interesting thought. John Coogan from System 13. We're a data warehouse here in Virginia. And so that's, duplicate claims are so common. And a lot of times we'll get overlapping claims where you've got the same patient on the same day with slightly different from and through dates where they overlap each other and one claim is inside one we tend to default to the most recent claim and by what we're instructed to do with our clients is to use that as the one that we accept. We take the most recent as the one we accept, like in the process of removing duplicates and stuff. And I wonder if that's maybe not matching up to the same ideas being implemented in the APCD data. I don't know, just food for thought there.
Yeah.
Thanks.
That's a very, very good observation. Anyone from the APCD world want to comment on that? Sounds like no. Okay, that's fine. Yeah, that is a very interesting idea, though. Any other thoughts or comments on external validation and what to do when the hospital data doesn't match up very well? Well, we can always come back to this. But I do want to take this. So now that we've kind of gotten through our introductory exercise, which actually had a lot more discussion than I anticipated, that's great. I want to recognize our Hospital Data Initiative sponsors. So System 13 and H-Metrics are our sponsors for the Hospital Data Initiative, and we're very appreciative of their support to make this happen and bring this to you. So we're going to go ahead and move on to another question for today. And this is going to be our next, this is kind of like the big question. For those of you who work for state-based, and which could be hospital association or other hospital discharge data collection processing, we would like to know what approach you have with regard to internal versus external support. So this one we're not able to do in the chat, so we have it only there as a bit.ly link that takes you to a Google form. And it's just a very simple question, which just asks you to describe your state's system for whether you're using internal resources only or whether you're using external resources, what kinds of external resources you're using, and then your level of satisfaction. So is what you're doing working, I guess, is the way that I would pitch that. So those are just two questions. We'd like you to kind of maybe go ahead and take a second, just pop that up if you work for a state-based or a hospital data program. And so obviously this doesn't make as much sense for vendors. And Charles has made that easy for you by popping that link in the chat. So those of you who have the chat can just click on that. Those of you who don't have chat, you just need to type in that short address and have that ready to go. So while you're completing that, let me maybe just seed this discussion a little bit with some ideas. There are a lot of ways that the hospital discharge data can be collected and processed. So in addition to understanding what challenges you're facing, just kind of knowing what kind of systems you're operating and whether those systems are working for you would help us plan for future topics that we can help understand the data collection and processing side of the equation going forward. So that's why that question is important to us. It's intended to help us identify areas of interest where we can be supportive and help you with ideas going forward. So just give you another minute or two to fill that link in. Hopefully we're getting responses. I can't see that. Charles is going to have to tell me when we've got some responses in there that we can put on the screen and talk about. That another minute or two for Charles to.
I think we just need 1 moment to respond. They're coming in slowly. It does look like some of you are getting blocks. So
Is there a way for them to put it in the chat if they are blocked, Charles?
Yeah, I was just gonna put the response really quick so people could kind of see. So give me just a second here. Maybe the long link will help. What I think is often happening, Richard, is that certain enterprise setups will not allow for connection to Google in some way or another. So that's probably what is happening. So let me, if that's, I hoped it would. We don't worry about those for now.
Let's do this. I've got a couple of other discussion questions. So maybe while people are figuring that out, getting those answers, the first discussion question, the extra one on beyond that is, are other data aggregators using an updatable model for their patient master indexes? So this question, it wants to talk about both of these are about patient master indexes. So for example, if you receive a new patient with enough information to create a new index, then later you receive another claim for the same patient with more information, perhaps now it has a phone number, or it's got something that your original record. What do you do? Do you update the original patient master index record with the new information, or is it pretty much static so that information does not get captured? Or do you end up with a duplicate because they don't have exactly the same information? So I hope that's not too much in the weeds, but that was one of our attendees was interested in that question. So would any of you who run these programs tell us if you know how does that work on your system? Okay, so yes, Natalie, go ahead.
I guess clarifying question, it would be the same answer, but we don't have a master patient index for our hospital discharge system. We have a unique person or a unique ID per claim that we try to say is the same person, but it's not a very robust algorithm by any means. On our all payer data side, we do have a master patient index, and we use a software that does the linking or master mastering for the IDs. And so within that process, there are rules that are done ahead of time for that process where we say to what extent we think that those IDs should be linked, and the software helps us identify whether they should be linked, the probability and all that other kind of stuff. And then there's a process of linking and delinking for all others that are sort of anomalies, kind of like it's almost a manual review. I have to say, in our APCD, we have so many that we have not gotten to a good linking and delinking in our APCD environment yet, meaning we know from our analysts that we've seen claims in there where, multiple master IDs have been attributed to a single person that we know is a single person. And so that would be an instance where we need a process through our software where we would unlink those people and assign them a singular ID. Link those people and assign them a singular ID, etc. So I guess long story short, you need some kind of rule that is consistent. If you're doing your own homegrown sort of linking through various tools, you just need to work on what the rule and the consistency for that is.
And I think that's an interesting thing. Hadn't occurred to me that, so for example, when Charles and I were working with Utah's both APC and hospital data, in the APCD, we had a provider table, which had a list of all of the providers that could show up on a claim somewhere, like a huge
Yep.
headache, as you can imagine. And so we did not want to have duplicates in there because there were enough duplicates already, just naturally occurring. But we did try to make sure that as we got new information that we kind of kept that refreshed. But we didn't have a table of all the patients. We didn't have a separate table, which was here's all the people. We had an eligibility and enrollment file, which kind of acted that way in the APCD, but it kind of really didn't because there could be duplicates because they had more than one plan, right? So if somebody is dual enrolled, then they're going to show up twice naturally because they're in two different plans. But that's an interesting thought, is how you think about the ID numbers for the patients really matters. So if somebody has a table, which is supposed to be one row per person in the state, and that's it, that's a little different than just making sure that we are trying to create IDs that match people across different places that they show up. A little different approach.
Yeah. And that's sort of what we did with our APCD master patient index. Natalie Helbig, could come in one year with Medicaid, like a Medicaid coverage. The next year I might move to an essential plan coverage. And then, hey, maybe I had, a commercial coverage in the third year. The goal is to link that person across those coverages and such. So,
yeah. So it's one record per person that documents all of the places they show up, whether that's as an eligible enrolled person, or whether it's a claim or some other thing, wherever they show up. Yeah. Okay. Anybody else want to tell us how you handle this idea of master person or master patient index? I hope, Charles, I hope you're monitoring the chat because I have only a very small window and there's too much going on already.
John just asked kind of an additional question that's related. Coogan with System 13 asks, anyone creating new patient master index records from newborn claims, which can be incomplete. Anybody who's worked with maternity claims knows that newborns are hard to identify, and linking mom and baby is tricky. So anybody out there creating new patient master index records for those newborns?
Or just I mean, this is a really like classic hospital data question, which is, how do you know who the newborn is? Do the hospitals give you enough information that you actually know who that newborn is? I know Charles and I, we struggled with that back in the day. You see all sorts of weird stuff come in on the hospital information. Like, some places would just put the mother's name. So the baby now has the mother's name, or who knows what, right? Because sometimes babies leave hospitals and they don't have names yet. So they would just plug in a mother's name, or they plug in who knows what. So let's maybe just take a minute and talk about, in fact, that was my second question I was going to bring up, is what are you doing? What are we doing about newborns? And I didn't see the full comment, but I saw the three-letter acronym SSN. That used to always be a problem as well, because newborns didn't have social security numbers yet. And so they would pipe in the mom's social security number or some other weird thing. And now I think it's even worse, because most of you may not even be getting social security numbers at all, ever. So you can't go back and retro edit those hospital records with the baby social security number, because you may never know the baby's social security number. So John's
comment suggests that the records actually have more complete SSN and name now, so that they're more often complete. And then Natalie says that New York requires the hospitals to add the mother's medical record number, MRN, to the baby's discharge record, and that helps. And she mentions that they have seen hospitals stop sending SSN from 2018 onwards. So that fits with what you were saying, Norm.
That's depending on a lot of things. That SSN, by the way, for everyone, just to give you some idea, I think many of you have been to the airport and have seen the screen that says people waiting for a seat assignment, and it has the first three letters of their last name and the first letter of their first name. as if that's supposed to like tell them that they know who they are, but nobody else does. But without risking any duplicates, so there's no little confusion about who it actually refers to, which is okay. So you've got a plane that holds 200 people, and there's, I don't know, 10,000 people in the airport. That seems like the odds are pretty good that you're not going to have a lot of duplicates. We went back and did a similar exercise with the hospital data and looked at social security numbers because there are duplicates, right? There are people who have the same name and the same birthday. It does happen. If you have the last 4 digits of the social security number and the first 3 letters of the last name, that gets you to 99.99. I think it was, we got up to 3 nines on that's good enough. And if you add in the birth year, it gets you like 2 more levels of 9. So like 99.999999 of people. So we looked at Utah's population. We got a data source that had about 3 million people in it and it had that information and we could check. So on a population of 3 million people, there were about, with that level of information, there were still duplicates, but it was less than 10. So the number of people who have the same last 4 of their social security number, the same first 3 of their last name, and the same birth year is about roughly 10 people on 3 million. So it does really help a lot to have social security number or some other unique identifier that is consistently maintained. Okay.
Natalie mentions that there's a group in New York linking hospital discharge birth records, mom and baby, to vital records, birth certificates. We did pilot where software like Informatica or other MDMs tools try to link mom and babies, and without really looking at the records, it doesn't do great. The team here has a very sophisticated SAS Python code that links hospital discharge or vital birth certificates, but the MDM tools that are supposed to do it doesn't like it as well. Only that made me laugh alone. Just the beginning of the sentence is funny. There are only 250,000 births a year in New York State. That's a lot more than in Utah, I can promise you. There are 2.3 million discharge records.
It is more. I'm not sure I would say it's a lot more. Utah has about 50,000.
It's not 10 times as many. Yeah.
Not 10 times. Yeah.
Considering it's 10 times the population.
Yeah, so Utah has about 50,000 births a year. I think it's probably gone up. It's probably close to 60,000 now. So, but yeah, that's if you're only having 2.3 million discharge records and 10% of those are births. This is a big enough area that it's worth figuring out and getting it right. So, any other thoughts from those who've had experience with that? Danielle, do you want to come off mute? Danielle, just can we share some thoughts from Washington?
Yeah, we use machine learning linkage, and we link from the baby's birth certificate back to mom's discharge. And it seems to be working quite well, but we have a robust linkage team that's been working really hard for various linkages, both within discharges down to get it down to a patient level and amongst other vital records.
So, so I'm assuming that you probably are above 99% success on that project. I would guess if that's what you're using.
Yeah, they've been staying at about 99 in terms of sensitivity and specificity.
Yeah, which is fantastic, right? I mean, it's hard for me to say this, but the data we do is not always life and death. So 99% works. I mean, if it was 99% and this was like deciding what medication to give to somebody, I may not be quite so thrilled with 99%, but for the sorts of things we do, 99% is actually pretty much fantastic. Yeah. New York is at 99 as well. I'm imagining that it takes effort, but there is a pretty good option of getting out there. Yeah.
In Washington, we don't collect hospital data from things like birthing centers. So that's a known miss for us that accounts for some of this.
Oh, okay. So if the babies are born in a birthing center, they show up in vital records, but they don't show up in the hospital data series.
Right. Exactly. Yep.
Is that on your list of things you would like to get at some point?
If we had a great wish list, perhaps, but hospital records are state mandated to be delivered to the Department of Health, so it takes a legislation change, and that's not in our control at DOH.
Yeah, we fortunately, Charles and I, when we were in Utah, we enjoyed fairly broad authority. So the statute gave us authority to require people to give data if there was a justifiable reason for collecting it. So for us, that would have been something that we would have gone after. We would have gone to the birthing centers and said, we need this data because we need a complete picture of all of the birth encounters for the state, and probably would have gone after that one. But now we're back to the question we had earlier, which is sophistication, right? Birthing centers probably are going to struggle to get you the data that you want in the technology format that you want. And so it's a costly endeavor. I would just put it that way. So yes, very good. All right. Other thoughts on newborns and or people indexes, anything like that? All right. So Charles, let's go ahead. Do we have enough responses that we can talk about the variety of ways that people are approaching this support problem?
Yeah, I mean, we have the typical small n problem of small surveys with only a handful of potential respondents to begin with. I mean, there's more than a handful of you. There's almost 50 of you, but we got 7 responses here. And I think what's interesting here is just that it's a pretty wide distribution. We did have a couple of, you see, these are, so the 14.3s are 1 response, and these are 2, where it's 28.6. So across, interestingly enough, you have kind of this distribution across the categories that we gave, which kind of go from complete contractor control, as you may have seen in the chat, to essentially an internally developed system. And it looks like you have kind of 2 bookends and then 1 in the middle for each category here. Oh, no, there's actually not an internally developed system that's maintained by a contractor. So it doesn't look like we have a value for that one. And then we have a couple of custom, or I'm sorry, other responses, I suppose. One of those is that Texas is collecting ANSI 837 billing data. One question that I have about that, just really quickly, is whether or not that's being done via the actual 837 transactions. It sounds like it. Is that fair to say? Does whoever responded know the answer to that?
Yes, the vendors are sending us a copy of 837 data, and we're extracting the claim information from that.
Okay. Yeah, great. So that's interesting. And is a system a bit, I believe Natalie can tell me if I'm wrong, but perhaps a system a bit more like New York, which also leverages the standard claims transactions. And then this last response says our internal staff helps supports data quality. So we talked about, Norm and I talked about the complexity of this particular question, whether or not we ought to have more of a grid for all the various aspects of the data quality lifecycle. But data quality certainly is one that's very directly tied into collection and processing. And it sounds like this particular respondent has internal staff doing that portion of the work. Presumably there's a contractor doing the rest of it. And then the last question about satisfaction. This one I think is interesting just because we see a wide distribution in the first question of potential options or solutions that people are leveraging. And then here you kind of find out that they're satisfied, kind of what Irvin and was it Richard in the chat that were kind of saying they had one had kind of an external system, one had an internally developed system. And they both kind of gave the same level of satisfaction answer. This sort of fits with that. Everybody's relatively happy regardless of who built the system. So. Is there any clarifications now? I'm trying to figure out if any of you corrected anything I've said. So Donald says the Arkansas is an internally developed system, but the health department collects the data initially, and then at ACI they do their own, which is the Arkansas Center for Health Information or Improvement. Yes, that I is important. We do our own ETL with the data from the health department. Improvement, thank you. I think Kenley corrected me on that recently. So that makes sense. And I believe that there are probably a number of other systems that are similar, although they may not be getting the data from the health department. Instead, it may be the health department getting the data from a hospital association, having to kind of do something of an ETL themselves or through a vendor.
I don't know. I think that we've probably had enough discussion on that. It's interesting to me that people are. I mean, again, so small sample aside, but people are all over the place. That there hasn't been a vendor that has come in and said, "We've got the solution. Just pay us and we'll do it for you." And everybody's just doing that. Some people are doing it completely internally, like Arkansas, and it's all over the map. So that's kind of an interesting thing to me to know that to each his own, and it's working out quite well because it appears that most people are either very satisfied or very satisfied with what's happening. 4 and 5 are the good numbers, right, Charles? All right, just always check. Okay, all right, everyone. Well, thanks for the time. That's what we have. If you have suggestions for our November meeting, please kick that along. I do want to put in a quick plug for the NATO virtual conference. That will be happening November 4th through 6th, and with 3 pre-conference presentations. If you haven't registered, please go to nato.org/conference/2025. You can get more information. You can see our exciting lineup of almost 100 speakers will be participating. It's virtual, and if you're interested in getting bulk discounts, there are significant bulk discounts for people that are bringing more than 3 people. It can get pretty cheap to bring those extra people. So please let us know. We would love to help you get your whole team involved. So thank you, everyone, and we will see you all.